a good big thanks to Usha and AyurCentral team for choosing me to give this presentation. Am I audible? Am I clearly audible?
Yes, doctor, you are audible.
Okay. See, I'm a small time practitioner in a government setup. So I have been practicing, I am doing my service for government since last 2.5 decades, and I do not have a private practice of my own. So, in one way, why I am tell this is because my resources in my hospital in the form of pharmacy or investigation, whatever we get, is limited. So all these years I have been practicing with whatever I have. So my approach to the diseases are limited to whatever the accesses I do have. So probably for people, I say I don't have an access to many of these what you call it as proprietary medicines in my hospitals. So whatever I get, I do to manage with all the medicines what I have. So whatever presentation or treatment aspect I'm going to tell you today is based on my clinical practice. It's not something area I'm going to speak about. And typically I have chosen the diseases as migraine and acid peptic disorders, not something in Ayurveda. Because once you give a Ayurveda nomenclature for particular disease, no, by controversy erupts. Two people are of opinion that this may be that, why did you take that diagnosis, why you are taking this diagnosis. So I don't want to take controversy. The clinical entity or the pathology which I am going to speak is definitely migraine and acid disorders. So this is my experience or my journey in 2.5 decades in government service, how I have come across these two conditions in my service and how I try to manage it. Can I have the next slide, please? Yeah. You also know migraine. Migraine is not just a headache, it is more than a headache. Next slide. Yeah. The common symptomatology. See, it is not that none of you know these things. Everyone who is here is definitely aware of whatever I am going to tell in the coming 30-40 minutes. But this is just a refreshment of it. The common symptomatology. So usually it is a unilateral popping or pulsating pain in the head, typically associated with nausea, photophobia, phonophobia, dizziness, fatigue, and mood swings like that. See, all these symptoms, not compulsory in all the patients. You have some symptoms in some patients, you may not have some symptoms in some patients, but these are the general way a migraine presents in clinical. Next slide, please. Yeah, epidemiology and burden. See, this is, of course, this is a worldwide statistics. The statistics changes from place to place, from nation to nation, from one climate to other climate. But the statistics says it affects almost 1 billion people worldwide. Prevalence is around 20 to 15% of global population. 3 times more. See, basically, migraine is a disease of 3 times. So basically, the majority are 3 times, or 2/3 of the patients what you see in your clinic, or maybe the 3/4, are typically they are women. We get women what we get. They globally ranked as the second highest cause of disability in terms of years we breathe disability. That means a particular pathological condition or a particular ill health is troubling you in terms of not leading a healthy life. So in that it ranks as the second one in the global. Next one, please. Cases of migraine. Hello. Yeah. Phases of migraine. See, basically migraine presents in 4 phases. First is the prodrome phase or the warning sign, which occurs up to 24 hours before the headache symptoms starts. See, this is not compulsory. Means it doesn't mean that all the patients who end up in our clinic do have all these symptoms. Only few people have and few people do not have. See, this is a collective representation of how a migraine can represent in different ways. So in this prodrome phase can start as early as 24 hours before the actual headache starts. The symptoms may include mood changes, fatigue, craving for food, frequent yawning or neck stiffness. Next is the aura. Again, this is sensory disturbances. See, aura affects about 50 to 30% of the patients of migraine, not all the patients. So here, what we see is reversible nervous system symptoms like visual disturbances, tingling, numbness, which lasts for 5 minutes to 1 hour, like this. Next, can I have the next attack, the actual headache phase. The peak pain phase with severe throbbing pain, nausea, vomiting, and sensitivity. See, this is where the patient is troubled a lot in this particular phase. The last phase is post-Rome phase, like migraine hangover, where the symptoms, few symptoms you can see after the headache comes down. It may include confusion, a feeling of out of sorts, means you don't feel like doing anything, you have lethargy and all those things, which may last up to 48 hours. Basically, a clinical migraine, a typical migraine can last from 4 hours to 72 hours, means spreading over a period of 3 days. If all these symptoms are seen, all these phases are seen in a patient, right from prodromal symptom to the post-traumal symptom, so it can spread up to 3 days each attack. But you may not see this typically in all the patients. And each patient, same patient may go through different types of the clinical unfolding at different days. It is not that this same patient had only pain, next time he may come up with some other symptoms also, means aura and other things. But typically aura is seen in few patients or not seen in few patients, but things can change clinically. Next slide. So, subtypes of migraine. Again, migraine is divided into, based on clinical presentation and other things, a common migraine and a complicated migraine. A common migraine is most common type of migraine, what we clinically come across. Majority, say almost 75% of the patient who land up in clinic for treatment of migraine do have this type of migraine. It is not associated with aura, but other symptoms are present. Aura is not there, but other symptoms like predominant, post-dermal and actual headache is present. Then the complicated migraine, what we call it as, preceded by aura, that is visual, sensory, speech disturbances and all those things. Then again we have premenstrual migraine, pediatric migraine is migraine occurring in young children. Premenstrual migraine is migraine which is precedes the menstrual, what is called as your menstrual cycle or your bleeding time, or hemiplegic migraine, where we can see temporary weakness of one part of the body associated along with the migraine. A hemiplegic migraine I have only read in theory in my 25 years of practice. I have not seen a case of hemiplegic migraine, but it is there in theory. I have not come across that type. Others, premenstrual, pediatric are very common. Can I have the next slide, please? And causes and risk factors. See, again, the why I chose this two diseases means, see, there are few diseases which have specific causes and specific risk factors. If you can avoid those causes and risk factors, probably you will not suffer from those conditions. And migraine is one such type. So if you have a familial lineage for migraine, of course you cannot avoid that risk factor. But other things can be, if you can avoid, definitely you either you may prevent that particular condition happening, or you may suffer less. So it is basically believed to be a complex interplay of genetic and environmental factors. See, everything exactly how it happens is not understood, but there are some theories, so let's not get deep into that. Then it involves changes in brain chemicals and activity of trigeminal. Trigeminal nerve sensory pathway is the main thing in any sensory activity which happens in the face. So trigeminal nerve has a definite role to play in this. Then there is family history, of course. Up to 80% of the cases you have family history, which cannot be avoided. This risk factor cannot be avoided. Then being female, again, this is one more risk factor which cannot be avoided. Especially female, middle-aged female is more at risk to develop this migraine. Then conditions like depression, anxiety, sleep disorders. See, these are the few conditions which definitely can be avoided. So this can, if you can avoid these things, probably you may not suffer from. See, if you have a family history of migraine, then you are a female. If you can avoid these next few conditions which I have told, so probably you may suffer. You may suffer less from the above said complaint. Next slide, please. See, next the common triggering factors. See, at one point we have common risk factors and predisposal factors. At the other end, what we have is triggering factors. See, suppose you are a family known for this migraine. You are a female, so there is every chance that you may develop migraine. But there are some triggering factors. For example, say stress, or And see, typically migraine, the triggering factor is different to each individual. See, in my practice, I have seen a person who goes out to bright sun. For one person, if that is the triggering factor, the other person it is skipping a meal. For the third person, it may be stress. For the fourth person, it is he travels for a long period at a stretch. A person who attends a function, a person who attends a place where there is lot of noise. See, each person, this triggering factor is individual. So you can see these are the few triggering factors I have mentioned here. That is hormonal changes. See, the lowering of estrogen can trigger a common migraine, whereas high levels of estrogen can trigger a complicated migraine. A stress up to 80%. Then dietary, like skip, as I was telling, skip meal, alcohol, certain foods. Means few people, if they take this spicy food, or if they take this deep fried food, or if they go to this plain food, they develop migraine immediately. So these are individual risk factors. Then sensory stimuli, as I was telling, bright light, attending a party with the huge noise with bright lights, or traveling for a long time, strong smells, all these things can trigger. Then sleep changes, too much of sleep or too little sleep. So again, this can also lead to migraine. See, and few people I have observed them telling that if they try to take a small nap in the daytime, immediately they develop headache. See, like these few triggering factors are individual, not common to every patient, so they have to be addressed individually only. Then weather changes. Like peak summer can trigger, the patient is very happy all the season. When it comes to summer, he develops migraine every other day. So the weather changes can also influence the occurrence or triggering the this pathology. Next slide, please. Diagnosis of migraine. See, this is basically whatever I am telling is based on allopathic system of medicine. So I am not touching anything, I am not telling anything in Ayurveda for the diagnosis purpose. Because as I told earlier, see, if I tell Ardhava Vedaka, then few people may question why not Anantavata. Somebody may question why not Suryavata. So I don't want to get into all this trouble. The clinical entity, what I am speaking is very clear, it is right. So diagnostic criteria is, see, the International Council of Headache Disorders, the third chapter says it has given few criteria for diagnosis. 5 or more attacks, 2 migraine with aura. This means if 5 or more attacks of common migraine, if it is migraine with aura, then 2 attacks. Attack which lasts for 4 to 72 hours. Means if you have an headache which lasts only for half an hour or 1 hour or 20 minutes, technically you cannot consider it as a migraine according to ICHD. Then headache has at least 2 of the following. That is, see, the headache should have at least 2 of the following features like unilateral location, pulsating quality, moderate to severe in intensity, aggravated by physical activities. If a patient has any 2 of these qualities associated with minimum 5 or more attacks, if it is a common migraine, or 2 attacks, it is migraine with aura, and which lasts for not less than 4 hours, then only we can typically consider it as migraine clinical. Headache associated with at least one of the following, that is nausea, vomiting, photophobia or phonophobia. So headache should be associated with nausea, vomiting, photophobia, phonophobia. At least one of these following. So these 4 criteria are listed in ICHD 3.2, typically labeled it as migraine. And migraine is basically a clinical diagnosis. There is no laboratory investigation or image studies to prove that it is migraine. So migraine is basically clinical history investigation, clinical diagnosis. Based on these criteria, we come to the conclusion that patient has migraine. Next slide. Then differential diagnosis. So what are the things to be considered when the patient comes to you with the main complaint of headache? So what are the other pathological conditions we should consider for DD? See, ruling out secondary causes of headache like humor, aneurysm. See, all of us know that anything which increases intracranial pressure can cause headache. So any space occupying lesion within the cranium can cause headache, then aneurysm, then hypertension. We know many of the patients with hypertension have presented to my clinic only with a symptom that the patient has headache. There is repeated headache, no other symptom. So see, headache can be the only, headache can be the only symptom in hypertension. Then of course we do have sinusitis, trigeminal neuralgia, so on and so forth. So we do have many other pathological conditions in which a patient presents to you with only headache as the main symptom. So we have to consider all those clinical conditions before coming to conclusion that this is migraine headache. Next slide, please. So after taking to, after going to the, to the patient, having a conversation with the patient, after noting down all the things, now we are supposed to come to a conclusion that this is headache. I mean, this is pure migraine. So for that, we have to do a few things. See, majority of the patients who do have migraine do come to us as a chronic condition. Very occasionally, very rarely have seen an acute case of migraine, a patient with an acute migraine presenting in my clinic. So usually it's chronic condition. And they come to, see, we Ayurvedic, people with migraine come to we Ayurvedic practitioners as by default in many other chronic conditions as the last resort, not as the first choice. Means once after trying all other options available to them, like allopathy, home remedy, social media remedy, Google remedy, all those things, they come to be Ayurvedic practitioners as last resort and they expect a miracle permanent cure from us for this. Next slide, please. So, also many times they do have some other, as I was mentioning, associated pathological conditions. Like DD is different. Like you are trying to differentiate the pathological condition the patient is suffering from is this because I am taking some other conditions which have same clinical presentation, I am ruling all those things. But this is something like what we call it as Varisankara in Ayurveda now. So patient do have migraine, but they do have some other associated pathological conditions like it may be refractory error, sinusitis, undiagnosed hypertension, along with this migraine, which makes things difficult for us to treat. So this also we have to consider. Then aggravating and triggering factors like acid peptic disorders and so many other things. So while treating migraine, we have to consider other pathological conditions the patient is suffering from, like any other disease possible. And this becomes more important. Why? Because that's what next I'm going to tell. First make sure that the patient has only pure migraine. That is, if rule out other things. If you in any way, if you come to know that the patient is suffering from some other pathological condition other than migraine, especially in those headache is also one of the main symptoms. In my experience, I have always tried to treat those pathological problems or address those pathological problems to begin with, rather than treating the migraine in the beginning only. See, and we as a practitioners, sometimes we try to get carried away because the patient comes to us and he gives a list of symptomatology which perfectly matches with migraine. At times we also get carried away and come to a hasty decision that, oh, this is migraine, let's start treatment for migraine. Let's not do it. Let's take some time. So if in any way you feel that the patient has other problems also, so first, I usually what I do is, for example, if a patient has hypertension or if a patient has diabetes, along with migraine, I try to address that problem first, then come to the treatment of migraine. Because many a times what I have seen is the next evidence. Yeah. So when you treat these associated causes, other pathologies associated with migraine, or at times when you treat the triggering factors or aggravating factors of migraine, many a times the headache has vanished in patients without actually treating exact treatment for migraine. Means the patient has undiagnosed hypertension and he has migraine also. You treat the hypertension first and have seen in many cases either the headache comes down, the migraine headache problem solves, or the severity and intensity of the migraine comes down. Then it becomes easy for us to tackle that problem. Same with sinusitis. So like this, so first, before starting a treatment for migraine, identify co-associated morbidities or aggravating and triggering factors. First, handle them or treat them or manage them. Then it becomes easy for us to treat the migraine per se, clinically. Next slide, please. Can I have the next place? So this is what I was telling about. So treat the triggering factors or the aggravating factors, or wherever possible, try to avoid triggering factors and aggravating factors. For example, if acid peptic disease or is the triggering factor for migraine, the patient has migraine, but the patient never develops headache. He develops headache only when his gut is disturbed. So he has an APD. So if you treat APD, the migraine vanishes. So the patient, because you are treating the triggering factor or the aggravating factor, you may not see the patient suffering from headache again. So first identify these triggering factors, aggravating factors and comorbid conditions, then treat accordingly. So then it becomes easy for us to manage headache or this migraine. So in my practice, what I have observed is majority of my patients who come to me with, patient has come to me and I have seen that I have confirmed that the patient has migraine, but majority of those patients do have sinusitis also. So what should I do now? So now comes the actual treatment aspect. See, as I was telling earlier, because I do have a practice in a government setup, so I don't have a wide range of medicines available in my pharmacy. The majority of the patients, who land up in government hospital do come here because they do get free treatment and free medicines. It is not that we do not have quality medicines, but the range is restricted. So all these years my practice has been aimed at managing the conditions with whatever resources I have. The way is making best use of my limited resources to what I have. So in majority of the cases, not only migraine, the treatment, I have a little option of few medicines, maybe countable in one hand. So these are the set of medicines which I have to manage one particular condition. So I have been managing with that only. So with that experience I am speaking here. So if I feel that the patient do have sinusitis along with migraine, what I do is, initially I start with Diagnostic 20 AD and Sudarshana Ganavati 20 AD for first 1 week, along with Chitrakadi Vati or Sudarshana. If there is something like symptom like something like Ajirna or Avipatti Karachurna, if I see Pitta, so something like this. So first 1 week I do not give any other medicine other than Diagnostic because Diagnostic has been told you Amapachan also. Then Sudarshana Ganavati, Chitrakadi Vati, Sudarshana. If Diagnostic is not available in my pharmacy, then I make use of Peptic. So this is how I treat. So first 1 week or 10 days, I do these medicines. So I ask the patient to come back after a week or 10 days, along with other things. In majority of these cases, the sinusitis would have been addressed these days, and few cases the headache vanishes permanently because it was a triggering factor for them, or there was a confusion in the patient also, probably it means also we came to the conclusion that the patient had actual migraine, but it was only sinusitis which was mimicking migraine symptomatology, and the treatment is good enough to treat the sinusitis and patient feels better. So this is one scenario. Next can I have? Next, once this is done, so this is sinusitis, means the case one is a patient has sinusitis, migraine along with sinusitis, so initially treat sinusitis, then once that is comes to some control, then actual treatment start. Usually I go with Chitrakadi Vati. See, this is one particular medicine or compound medicine which was told in our Shastras, which is supposed to be told putting headache of any origin. This is headache of any part of this headache arising from any part of the cranium, like temporal, whatever it is, or frontal region, and headache or due to eye problems, headache or due to lecture problems, all those things in this Charakadara. So this is one particular compound of the Ayurveda which is helpful in headache of because of so many reasons. So this is 10 ml usually, and Jagari, along with Jagari. See, this Charakadara specifically says, he says Sharanga Kashaya, he says. See, we do this Patyadi Kashaya is typically Tripala, Bhunimba, Nimba, Nisha and Amruta as ingredients. So if you count them, it becomes 5 ingredients. Here he says Jagari is the 6th ingredient. See, Jagari in Patyakshadakari Kashaya is not an Anupana. Buddha is a part of the Patyakshadakari Kashaya which is called as Sharanga Kashaya. So by default you are supposed to add Jagari to Patyakshadakari Kashaya as a part of Kashaya and give it again once in the morning and evening. And I am not sure, I don't have any studies or statistics to prove that Even Pathyadi Kasha is given without Jaggery and with Jaggery, what the difference? No, I don't have that statistics. Because the Acharyas have told that it has to be given with Jaggery, I have been simply given with Jaggery, thinking it as after Vacha. So I don't have any statistics to prove that without Jaggery also it works as the same. I don't have, unfortunately. Then other one is Godanti Basma. See, this I got from, there's a book called Siddha Yoga Sangraha from the renowned Vaiti Acharya. You may know Yadavritti Acharya, who is the chief editor of Charaka Samhita, whatever we have today. So he has penned down a book called Siddha Yoga Sangraha. In that he mentions this particular yoga, Godanti Basma. He says 1 or 2 pinches of Godanti yoga along with same quantity of this chemical red sugar candy collected and a small quantity of ghee. So all these are mixed and taken as in the form of leha. So the first dose starts early in the morning as soon as you get up from the bed and followed by 2 to 3 doses till mid-noon. This is what he says. And this has worked really well in many of the traditions, and these two are almost inseparable ingredients of my prescription for every patient who comes to me with migraine, whether it is a complicated migraine or a simple migraine or anything. So these Pratyakshadakradi Kashayam and Godanti Basma, these two are compulsory are there in my prescription. Then we do have the third one, Shirashulari Vajarasa. See, Shirashulari Vajarasa is not always, I do not give it always. So only when you have CV8, the complex, what you call it as complicated migraine or something like that, no? I add Shirashulari Vajarasa. Otherwise, Pratyakshadakradi Kashaya, Godanti Basma will help. And sometimes I do add the Shakaras, I will tell. Then Varanadigana Kashayam. See, Varanadigana Kashayam is one more good drug which is known for its wide range of use. It has been told in Shirashula also. So, 2 cases I add Varanadigana Kashaya also along with Pratyakshadakradi Kashaya, where the patient do have hypertension along with migraine. No? In them also I would Varanadigana Kashaya, and in few patients with premenstrual migraine, I do add Varanadigana Kashaya. Can I have the next step? Can I have the next step? If APD, this is what I was telling. If APD is the triggering factor of this migraine, then usually I add Ladusut Shekararasa and Abhipatika Choda. So if the heartburns are more, the acid, the reflex is more, then I add Ladusut Shekararasa and Abhipatika Choda to Pratyakshadakradi and Godanti Basma. Sometimes instead of Abhipatika Choda, where the acid reflex is very high, I choose this combination, this Tripala, ST and Shankabasma. Or Shankabasma, Varatika Basma, Kaparnika Basma, Mukta Shuddhi Basma, or Pravada Pishti, whatever you have at your disposal, any one of them can be added. So if it more the Pitta, more it goes towards Pravada and other things. Otherwise, simple Shankabasma is sufficient. So this is one thing I give. And Dhatriloha at Sampamuta. I will tell Dhatriloha Sampamuta in APD. So these are the combinations along with Pratyakshadakradi Kashaya. See, all these are depending upon the availability in my pharmacy. I do. So many times I may not be having Dhatriloha, then I use Sampamuta Loha. If I don't both of them, then I don't think of putting Navayasarvana. That I don't do. Either one of them I go. Again, it can be Abhipatika Churna or Tripala, ST or Shankabasma, either Ladusutta Shekarasa or Kamadudarasa as per availability. So see, whatever I am telling is practically what I have been telling. So I have been doing in my government service. So there is no theory involved in it. So it is just practice what I am telling. Next slide, please. Then, see, this is the treatment aspects. As I was telling, my resource is limited, so I try to manage all the patients who come to me with only these resources. See, in a government setup, we can't give a prescription for medicine outside. So, which is usually not done. So that's why I have not listed. But there are few drugs which are available in the market which may help, like the Majapala Rasayana is one such drug which can help in APD conditions. Or you have Cefagran is there. There are so many medicines. I don't want to list any one of them because I am not using. So I manage all the patients of migraine who come to my clinic, hospital with only these medicines, and I do have a decent results with all these things. But more than these medicines, what I am telling next is becomes more important in management of migraine, like in what we call it as Patya in Ayurveda. See, first thing is see the triggering factor, see the aggravating factor. Every patient will definitely come with you that sir, bislu hodre, ikkabute talenovu jaasti agide. Either the headache starts or already if the headache it becomes severe. ಊಟ ಸ್ಕಿಪ್ ಮಾಡಿದ್ರೆ ಪ್ರಾಬ್ಲಮ್ ಆಗುತ್ತೆ ಸರ್. if I do attend a function or some guest come to me home, I get this triggered. So I have some physical strain ಜಾಸ್ತಿ ಆಯಿತು. For example, me, see, actually, basically I'm a patient of, I do suffer from migraine if I go to bright sun. Say I can't stand sun for long time. If I stand in under bright sun for half an hour or 1 hour, I do develop headache. I can't skip my needs. So I have been so meticulous in these things. Luckily, I do have such a profession that I do not have to work under the sun. So I never stay under the sun for a long time. I don't skip my meal. I take my food in time because I know it triggers. And off late, if I take a small nap in the afternoon or in the evening on holidays, I do develop headache immediately. So I just simply avoid those things. So this is what I am telling. So avoid triggering factors. Avoid aggravating factors as far as possible. So for those who are, that's what I am telling. Well, these are the practical suggestions what I have written which I give to my patients. So if bright sunlight is the triggering factor, then always advise the patient to carry an umbrella with them. If not possible, use a Panama cap, not that regular cap. Panama cap is that the cricketers is around their head. And not to stand, if their profession is like that, they have to stand under the sun for a long time. Ask them to take a break for every half an hour or 45 minutes, not to continuously stand under the block. Because, see, Ayurveda says, Sanshepataha, what is that? Sanshepataha, or avoiding the risk factor is the chikitsa, that is, Nidana Parivartana. Yeah, Nidana Parivartana chikitsa. So avoid the risk factors. The easiest treatment is avoid the risk factors. So if bright sunlight is the triggering or aggravating factor, try to avoid. Again, if skipping the meal or having a heavy meal or having this junk food, other thing is the triggering factor. See, one thing, irrespective of whatever treatment you give, if the patient does not avoid these things, he is not going to get benefited, or you are not going to give a good food to the this problem. So, meal, then spice it if as a consumption of good quantity of water, especially in summer. Less screen time, this is the newest addition to this thing. Probably this was not this, if you take it as sexual indriya yoga. Or stay calm and not to indulge in either physical or mental activity which induces stress. This is not only as an avoiding factor, as an aggravating factor. Means suppose you have developed a headache, it is mild in intensity, so try to avoid either physical work or mental activity when you have an attack. Try to stay calm as possible. That's why we see patients of migraine getting themselves isolated into a corner. The moment they reduce the physical activity and mental strain, the pain tries to come down. So once you are in an attack, in a case of either in the prodromal phase or in our case of aura or actual headache, try to avoid unnecessary physical activity and mental activity, which helps to either reduce the intensity of the or reduce the the periodicity and severity of the headache. Next, can I have the next thing? See, this is what is about migraine. See, basically, migraine is a condition, a clinical diagnosis, where the involvement of the patient or the what type of support the patient gives to himself to you is more important rather than the treatment what he gives. Intentionally, specifically, I have not included anything about Shodhana in this because though I am a Panchakarma specialist, but PG in Panchakarma, see, intentionally I have not added anything about Shodhana because I do not do any Shodhana in these cases. It's not that Shodhana doesn't help, but I don't want to tell something which I have not practiced. This is in my principle. So I am happy doing this thing. And so migraine is one such condition, even the APD, where you cannot find a magic result over 1 week or 10 days or something like that. You have to give yourself, the patient has to give himself some time, and as a practitioner, you also have to be patient. It is not that I have given some medicine, it will 2 weeks, the patient comes back to you, so there is no absolutely no improvement. So don't jump in a hurry to change the treatment. See, it takes some time because the patient has had this problem for nearly a decade or so, usually many of the patients. It is not easy to treat a problem which is troubling the patient for more than a decade in a matter of days and you clear it. No, it's not possible. As a practitioner, you have to be patient. As a patient, he has to be more supportive. And he has to make many adjustments and changes in personal life so that effectively you give a very good treatment. And it is not that migraine cannot be cured. It is not, it can be. I have many patients who have they have just stopped getting headache after few weeks of treatment. It's not that it is not possible, but the problem is in subsequent life, whenever they get exposed to this again triggering factors or aggravating factors for long time, again they tend to develop the same thing and they come back to square one. So this can happen in all those disordered pathological conditions which are associated with lifestyle or many of those associated with what we call as autoimmune conditions. You can have a permanent remedy, you can send a patient without any pain for a long time after treating, but the patient has to make some modulations or adjustment in his lifestyle and other things. So this is what I treat. So definitely if the stress is the major factor for triggering factor in migraine, then occasionally I do dhara. I do shirodhara, not sarvandhara, and I do not do Ekradhara. I do kshiradhara with kshira processed with ashwagandha, then amalaki, amhi, jatamamsi and yashti. So I make use of these 5 drugs to make a kshirapaka of this, and I do dhara. With this kshira, if stress is the triggering factor for the migraine, then occasionally maybe Satyavamana in patient if APD is the problem. Otherwise, I have not been using Nasya regularly for treatment of migraine. No other either Vamana I'm not doing. I'm happy with my whatever treatment I do. So this is all about migraine. Now let's come to APD. The why I chose APD is also one such condition which is something that's very commonly seen. You can see a lot of these patients coming across the table, sitting in front of you, sir, I have gastric. The only one complaint the patient will, sir, I have gastric. He may be having pain abdomen, he may be having regurgitation, acid reflux, or he may be having excess of flatulence, or he may be bloating of abdomen, or everything the patient has only one complaint, sir, gastric. Gastric. So patient doesn't understand the technicality of different things. So APD is one such condition which is very common in today's scenario. So APD is again typically it is defined as a group of disorders characterized by damage to the gastrointestinal mucosa from imbalance between acid peptic, these are the offensive factors, and the mucosa defense mechanism, as we know the protective factors. I need not have to elaborate all these things. Everyone must know this. Then mainly it includes 3 conditions: peptic ulcer diseases. It can be gastric ulcer or duodenal ulcer, which is a frank ulcer in these 2 parts. Then you have something called as GERD, gastroesophageal reflux disorder. Then either inflammation of the gastric mucosa or inflammation of the duodenum. That is gastritis and duodenitis. Next sentence. See, primary cause. See, as listed, expirer infection has been considered as the most common cause of APD. Then overuse or irrational usage of NSAIDs is another major factor for these 2. Then other risk factors include uncontrolled smoking, alcohol abuse, again irregular food habits, consumption of too spicy food, junk food, tea food. These are the things. Then stress. These are the common factors, and a rare condition like Zollinger-Ellison syndrome. Again, Zollinger-Ellison syndrome is a theoretical one. I have read it, but I have never come across a patient with Zollinger-Ellison syndrome. That is probably one case, long back, maybe 10 years back. I had a patient who was a diagnosed case of Zollinger-Ellison syndrome in my OP. Otherwise, it's just a theoretical thing. Next, please. Can I have the next slide? Hello? Can I have the next slide? Yeah. Common symptomatology. See, pain abdomen. See, this is pain abdomen is typically epigastric in nature. So upper it is known as a burning pain or gnawing pain. Then heartburns and regurgitations. Heartburns and regurgitations are very prominent in GERD. Burning sensation is rising almost up to chest or throat. Either pudi baige bandangagatte sir, visha bandangagatte. This is what you see. And I have one more thing I have left. You can have GERD in patients with lax series of gastroesophageal tension or hyperthermia. Once I had a patient in my OPD. He had such a relaxed gastroesophageal junction. This thing that if he bends over, his stomach content will come out. There was absolutely nothing in his gastroesophageal junction. If he bends like this, everything comes out. He can't bend it down. So it was totally lax picture. So certain patient I had. So that can be of course it is a structural problem which cannot be treated with itself. But when you consider GERD, you have to think about either hyperthermia or this one also. Then nausea, bloating, dyspepsia, and other symptoms are like heart or melina. Melina is only when you are having bleeding from the upper CAE. So these are the common symptomatology of any APD what we see. Next. Can I have the next slide, please? For diagnosis, this APD is not, though it is a clinical diagnosis, but we do have some investigations to prove it. Basically, upper geoscopy, where we are trying to prove that either to rule out there is ulcer or to know the extent of inflammation in the upper GI tract, and to know whether there is hyperthermia or any other thing. Then exploratory testing is done to confirm whether the patient is infested with it. It is a stubborn infection, so we can see exploratory infection. We know that it doesn't. It is many times it is very stubborn. It doesn't go in that reason. Can I have the next? So basically, APD. See APD again. APD also, if I give an Ayurvedic diagnosis, if I say Amla Pitta, maybe mass, why not? That does it. Again, Amla Pitta, why not? What is Udoga Amla Pitta? No, Adoga Amla Pitta? No. APD is APD for me. So either again, I'm confusing myself. I'm confusing you also. Many people have different opinion about all these things, so I don't want to get into all those things. So it is just APD for me. So again, treatment. So treatment options, what are the options I do have in my pharmacy? I'm putting, let me tell one by one. Chitrakadi Vati. See, Chitrakadi Vati is one such beautiful drug in our book that it can be used in all types of upper GI disturbances. Whether we have burning sensation, whether we have acid reflux, whether we have pain in the epigastric region. The patient says half an hour after taking food, there is some pain in epigastric region or retrosternal region, bloating. In all these conditions, Chitrakadi Vati, it has Panchalavana and other things. So it's a beautiful drug. Usually the method of administration is usually I give it for chewing after the food. This is how I follow. Maybe textually it may be different, but I do follow, give it for chewing after food. Then Lagasuka Shekarasa and Kamadugarasa. See, Lagasuka Shekara is pure Fornagarica process in Nagavalis society, whereas Kamadugarasa has, there are Kamaduga native, Kamaduga tail, plain, it is not Mukta, has both Abrata Basman and Puruchi. So if it is APD, with symptoms of GERD and other things, then I make use of Lagasuka Shekarasa, Kamadugarasa, either one of them. Lagasuka Shekarasa, for me, Kamadugarasa is a better option than Lagasuka Shekarasa. Otherwise, Lagasuka Shekarasa also will do. And I have not seen any better effect with Kamadugarasa with Mukta. Because it is not available, I don't use it. But we do have Mukta Shukti Basma in our pharmacy. So if I feel the Pittaja symptoms are more, then I make use of Mukta Shukti Basma along with Lagasuka Shekarasa if Kamadugarasa is not available, or Kamadugarasa with Mukta Shukti Basma. Then Datri Loha. See, Datri Loha is one drug which has been less explored or which has been less used as per its indications in the book. See, both Datri Loha and Saptamrutta Loha have been told in the context of Shula Chikitsa. See, Rogadikara of both Datri Loha and Saptamrutta Loha is Shula. See, in Vaishagya Ratnavali, the author goes to the extent of telling that it is the best treatment for all types of Shula, he says. So, Datri Loha is one drug which I use, usually I give it PID before food in all APDs conditions, which has given me very good result if I use, when I see, Previously, when I didn't knew about this particular thing about Gatiloha, I was not making use of it. But once I came to know about it, I have started using it, and I can see a practical change in the results what I get once I add Gatiloha. Even Saptamrita Loha also you can add if you don't have Gatiloha. This is given typically before food. See, Gatiloha says, see, it is one drug, same dose, different conditions, different Aushadakala, it says. So it is something like Amagirna, Vidagdagirna, Vistabdagirna, I think it is given before in the middle and after food, something like that. It says, this I have been giving in before food in usually APD. Then again, as I was telling the previous one, same combination. Triphala, ST, Pravada, Pishti, Mukta. This is one thing which has helped me a lot in conditions like GERD. Means half teaspoon of this in boiled and cold water, half an hour before food. See, especially Amalaki. Amalaki, you know, ST is Shokahara, and Amalaki, they say it has something to do with H. So either Amalaki or Triphala. See, I take 50 grams of Triphala Churna, 25 grams of ST Churna, 5 grams of Pravada, Pishti, Mukta, Shukti Basma, or Shankabasma, or whatever I have in my pharmacy. So this is given half spoon in half glass of boiled and cold water, half an hour before food. It serves the purpose. Then, as I was telling, Madhikal Rasayana, Jirakarishna. Jirakarishna is one again drug. See, either Jirakadileha or Jirakarishna. See, Jirakadileha for me has given better results practically than Jirakarishna, where we see Pitta and Nasya and all those things, you know. So Jirakadileha is a better option for me. Next slide, please. Then, other options what I have is Indukanta Kashayam. See, Indukanta Kashayam is again one beautiful drug where other than GERD symptoms, like you have pain abdomen, distension of abdomen, bloating of abdomen, discomfort of food. Otherly, Indukanta Kashayam, Sutta Shekarasa is good for me. See, Sutta Shekarasa is not a replacement for Laghu Sutta Shekarasa. Technically, practically, they are different drugs. So you can give Kamadhuda Rasa instead of Sutta Shekara, Laghu Sutta Shekara, or Laghu Sutta Shekara instead of Kamadhuda. You can't replace Sutta Shekara with Laghu Sutta Shekara. So I use Sutta Shekara Shankavati in problems of lower, means where there is you have bloating of abdomen, the feeling of pain, discomfort in the lower abdomen rather than in GERD. GERD I don't make use of Sutta Shekara Shankavati. Dhanantaram again is used as something like Pasmaspadic pain I use. Then either Vayugulika or Dhanantaragata. These are the few drugs which you do have in my pharmacy which I make use of. Sometimes I give Indukanta Gutta also which I had in my pharmacy. Very rarely I give you Gutta, but these are the few drugs. Can I have the next slide please? Yeah, thank you. So again in APD also, just like migraine, Patya and Ahara Vihara, whatever it has plays a major role. Timely food, not consuming junk food, not consuming very deep fried foods. You know the foods which aggravate your problem that you should always keep in mind, especially APD and GERD. See, going in empty stomach, see, what I have told, have different types of hours. Either Kalatita Bhojana, Achi Bhojana, Viruddha Bhojana, or whatever these types of things you know. Don't do it. See, APD and migraines are those two such conditions which can be very much avoided or can be kept under our control, means control of the patient, if you know your disease, if you know what are the triggering factors of your problem, what are the aggravating factors, if you avoid them, so there is no need that they should see us. They can maintain, they can handle their problems on their own. But unfortunately, as I was telling, Nidana Parimarjana Chikitsa is not happening nowadays, and they come first. And both these conditions can be definitely tackled very well. Again, I have not done any show. I don't show that I'm even APD also, because I don't feel the necessity to do it. Basically, it can be controlled with a little bit of, patya, that is Ahara Vihara and simple medicine. They can be kept under control. Again, having said that, again, APD is also one such condition. Once you go out of the practice, once the patient goes out of, he thinks that, okay, for 6 months, I've been good. I have no problem. Let me go one day, let me have some spicy food, or let me enjoy something party. No, you have to be under control always. Then you can keep this also under control. So this is my clinical experience in treating these two conditions. Many of all of you have assembled here, or probably you people are much experienced than me. You know better options than what I am telling. If any of you can come out with something better than this, definitely I am ready to adapt. I think I conclude with whatever little bit knowledge I have about these conditions I have told. As I was mentioning, what I am telling is only my clinical experience, what I have done. I am speaking nothing, I am telling to carry it. What I have done, I have spoken. I think the host is, I will rest my this presentation. Thank you for your patience.
Thank you, sir. Thanks for your wonderful insights and giving us an exposure as to how we can manage diseases even when we are having a very little resource. Participants, I would like you to unmute yourself if you have any questions. Dr. Ravindra will answer your questions. Or you may also type it in chat box, whichever is comfortable to you.
Namaste, sir. Myself, Dr. Supriya. So nowadays, fasting is being being health conscious people are entered. How will this affect on APD, sir?
See, fasting APD, see, that's what I'm telling. See, if you know your gut first, you learn. See, fasting not necessarily always should increase the symptoms of it. See, the problem in APD is the acid or the pepsin is attacking your the mucosal layer and causing damage to the mucosal layer. That's why you have this symptom. It doesn't mean that fasting always causes. The problem is, see, you are used to some kind of food habit. Means you are being used to taking food for some particular interval. Suddenly, one day if you fast, nothing happens. But if you go, means suppose for a person like me, who always takes his lunch almost at 1 to 2 every day for 30 years. So for one continuously for 10 to 50 days, if I change this, so if I start eating at 5 o'clock in the evening, then because my gut is ready to receive food at 11 o'clock. If I don't put, then the secretion, there are secretions ready to digest it. That may cause problem. Otherwise, intermittent fasting for short period should not aggravate it. I don't think it will aggravate APD. But another problem is, say one more thing I forgot to tell, a lax abdomen. This is the major reason for GERD and bloating of abdomen and this thing. See, keep your abdominal muscles in form. See, many a times the increased turbulence or bloating of abdomen, immediate heavy food is just because of the lax abdomen. If you do some exercises to tone your abdomen, the problem resolves on itself. Short-term fasting or fasting for 1 or 2 days should not practically or technically increase it. No, I don't think so. It will increase. It will never increase. If it is for longer period of time, then it may come. And somebody was asking, this APD can, Chitrakadi Vati can increase APD. No, I don't think so. In my practice, that's what I am telling. No, if bloating is more, see, I don't use Chitrakadi Vati in GERD, where you have more acid reflex. But see, if you have bloating, feeling of pain sensation half an hour after taking food, or something is throbbing pain, or adrenaline, something like that, there I use Chitrakadi. But in GERD, I don't use APD. Shira good for APD. No, APD, Shira is not a problem. I don't think Shira should be a problem in APD. It also depends what quantity of milk you are taking and when you are taking. See, if you are taking half an hour before food, if you are taking milk, then it should not help. Because it will take time to digest the food, milk. As Shira, as a routine, somebody was asking whether can you mix in Shira Pata. I think Shira Pata may not be a good choice in, I have not tried it, and I don't think it is a good choice in APD, but it's a good choice in Soraveda. I don't think Shira Pata should be good in APD, I don't think so. Shira should not be a problem if you use it in limited quantity. It should not be a problem. But if you have lactose intolerance, then it's a different issue.
Sir, and in migraine, if a person comes to the OPD and they want, usually they want an instant relief at that moment. How to manage that, sir?
So basically, that is not possible, madam. See, there are so many theories. Rakta Mokshana Madi with the Lalata. They bloodletting or Agni Karma, they tell. Again, it is, see, if you do Agni Karma, again, you are just pulling the pain, that's all. So you are giving a temporary relief and you are not looking at cure. See, every time the patient comes to you with, the next time the patient comes to you with a migraine attack, can you do Agni Karma? No, it's not possible. So, best way to get rid of or reduce the intensity as a severity of the pain is take off. Make the patient to see. Well, say there is a saying that once you know that you have such a pathological condition, it is better to understand the condition and live with the disease rather than fighting the disease. Just like many the degenerative body conditions what we see in old age. Migraine is one standing condition. Understand your disease well. If you understand your problem, many of the patients I do have with me, they have migraine, but they never end up in that acute phase. The moment they have this, the previous prodromal symptom or something like that, they manage. They do take. This Dodanti Basma is one thing. The patient has pain. He knows the patient is getting pain. Are you taking first dose early in the morning and subsequent doses? I have seen the severity of the pain comes down subsequently in subsequent attacks. That is one thing which I have observed is Dodanti Basma. It's good. It's good. One may not be. Say, I have no magic remedy to reduce the intensity of pain. I don't have. If someone has, tell me, I definitely will. I don't.
There's another question by Pooja Golapanavar. The question is, any views on Pittarejika Kwata and Pittaka Kashaya in migraine?
That's what I'm telling you. See, so whatever I have told is what I have practiced. See, for me, scope of prescribing outside my hospital is legally, technically bad. That's what I don't do usually until there is a the patient really needs some medicine and the patient is ready to purchase. So I have been saying, Pratyaksha Datradi Kashaya with Buddha or Varadi Kashaya, two good drugs which are good enough to maintain this. Or say, they are good. Pratyaksha Datradi, see, there is one more Pratyari Kashaya in the market, this I forgot to tell. See, be careful. We have 2-3 drugs in the name of Pratyari Kashaya in the market. So what I am telling is Pratyaksha Datradi Kashaya is one Sharangadara only. It is told, again there is one more Pratyari Kashaya which is told in Chakradanta. That is told in APD. See, that is told in Amlapitta. So if APD is a triggering factor for your migraine, that Pratyari Kashaya may help. So this is one more thing I am telling. Know the drugs what you prescribe. So before you prescribe drug, see if possible manufacturer yaru, ಯಾವ reference ಇದೆ. If the Pratyaksha Datradi Kashaya or Pratyari Kashaya, what you have is from Sharangadara reference, then it is for headache. If it is a Chakradhanta's reference, that is basically with APD and Amlapitta and other conditions. There is one more called as Phalatrikadi. See, Patyadi, Pratyaksha Datradi, again Phalatrikadi is Triphala only. Phalatrikadi is again from Sharangadara, but that is in Madhume. So, know exactly, there are few drugs in Ayurveda which have similar name in the modern market. References are different, so indications are also different. Make sure that you know what exactly you are writing. As far as Pratyavirechaka Kashaya, it is technically, theoretically it will be useful because I have not used it. No, I don't have any thing to give it. Sorry, I have not used it. Maybe if more, then you can use it.
Another question by Supriya. How about difference in usage between Chitrakadi Vati and Agnitundi Vati?
Oh, madam, see, this is something interesting. See, Agnitundi Vati I have been using as Deepaka, Kachaka, not in conditions associated with GAD. Me as a person. See, I have been using Agnitundi Vati as Ama, means Ama Shula, not Ama Shula, not pain associated with GAD. Other pains, pain in the joints and peripheries like Angamarga or the Amavata, the Shula and Amavata and other such conditions I have been using. I use Agnitundi Vati, I use Agnitundi Vati chronic UTI and other things. But I am not a person who uses Agnitundi Vati in problems with GAD. Basically, I make use of Chitrakadi. Chitrakadi Vati is problem in GAD. Agnitundi Vati, Ama in other conditions. I don't use Agnitundi Vati in GAD. Trigonakirtivasa is again I use because it is Ama Pachanabali held. The same Trigonakirtivasa you can make it in Amavata also.
We have another question by Mumta Kulkarni. How about Pratimarsha Nasya in migraine?
Yeah, madam, Pratimarshanasya, see, Pratimarshanasya, one way of Pratimarshanasya I've been using regularly, which is told in Sushruta SS, Bruhanirgakshamane SS, one of the types for using Pratimarshanasya SS as you go out of the house. This is one of the types he says. So this I have been using especially in allergic rhinitis. So I've been big advocate of this Pratimarshanasya, especially this particular usage, this before leaving your house. So this Pratimarshanasya, if the smoke and other things are the aggravating factors, then use Pratimarshanasya. Shadvitu Tela is something which I have been using regularly, not Anu Tela. Or you can put any oil. And one more thing is, I forgot, if the aggravating factor is sun, means the bright sun, sometimes to few people I ask them to apply plain Shirabala Tela to the small quantity of Shirabala to the scalp when they go to sun for work, or there is something called as Balahata Tela. This also I make use of. The few patients I explain. So put a little bit of Balahata Tela or Shirabala Tela on the scalp if they work in hot sun and bright sun is the triggering factor. Pratimarshanasya, yes, only in those conditions where dust and other things are, as I told you, strong smell and other things are the triggering factors, there I use.
We have one more question. Sir, why can't we use Takradara in migraine? Is it because of Amlaguna or Takra or any other reasons?
Hey, madam, see, of course, Takradara, I don't say Takradara cannot be used, but see, especially problems with stress, anxiety or depression. See, I have been accidentally, I did this Kshiradhara to one or two patients. There it was better for me. So I have been using Kshiradhara with medicines, what I told. No, so I don't know, many of these like Subraki, Ashwagandha, which are soothing and which are more relaxants. So Kshiradhara I am doing it. It's not that you need not have to Takradhara, there is no rules. But I have not done it. It can be done. Definitely it can be done. But problem is, Takradharadali Kelivurige, of course, Takra is supposed to be Ruksha. Sinusitis is a Takradhara case, of course. Kshiradhara also can. See, make sure that whenever you do Dora, patient has no associated symptoms. Sinusitis, if the problem can aggravate if you do that. Dara with anything. So, make sure that patient has no upper respiratory tract symptoms if you are doing Dara. Takradhara also can be done, but Takradharadali, I don't know, these medicines are but Kshiradhara has been good for.
We have another question by Rahul Gujia. A 20-year-old boy having headache regularly. Headache occurs in morning around 9 a.m. for 1.5 hours. After that, once again at 12 o'clock after food, and then once again at 9 p.m. Aggregating factor is Ratri Chavarana, Atapa Sevana and high sound. Sir, can we consider that as migraine?
Yeah, 13 years, it can be considered as migraine, but see there is something, probably it has to do with some stress, the patient is not, the boy is not able to cope up with school or education or the environment house. Try to
20-year-old.
20-year-old, I mean maybe, even in college, you see, again, this is a much bigger problem. If the patient is 20-year-old, definitely there is some stress. First, check for refractive errors. Check, see, as I was telling, before jumping into a conclusion that the patient has migraine, check for refractive errors, check for other associated sinusitis or any other upper respiratory condition, pathology. Then if you don't see any one of them, this can be definitely considered as a migraine. But see for triggering factors. See, you do a counseling with the patient. Try to know why that pain is being triggered. Initially, you do one thing. Let him give you this what I told and Sudarshana Ganavati and Ayurvedic or Chitrakadi Vati for 10 days. See the changes. Then do a counseling with the patient. Do have a talk with the patient for 5 or 10 minutes. Try to ascertain what is bothering him. There has to be something bothering him which is triggering this. See, getting pain in the morning, getting pain in the afternoon, getting pain in the night is something not common. It is not usually seen. See, the pain is. And one more thing, if the patient wakes up with a headache, majority of the times it is not migraine, it is a stress. But headache is due to stress. Usually, once the patient sleeps well at the night, the morning when he gets up, he should not get up with a headache in migraine. the patient gets up with a headache, usually there is stress also involved. It may not be migraine. See, go ahead, or send a patient to the psychiatrist, let them ascertain there is still something else causing the headache. And I think that is better to have a session with a psychiatrist.
Okay. So when to use Sudha Sekara Rasa, Kamaduga Rasa, Shankavati and Lagu Sudha Sekara Rasa?
See, Lagu Sudha Sekara Rasa and Kamaduga Rasa, use it in where you have GERD or where you have more acid reflux or where there is more of pitta symptoms like burning and other things. Sudha Sekara Rasa is usually the Sudha Sekara Rasa, and don't think that Sudha Sekara Rasa is safe. In many of the, I keep on advocating two things. You see, whenever you prescribe medicine, two important things we should remember. One is Rogadhikara and Palashu. The third one is at least have a decent knowledge of what the drugs you prescribe do contain. Sudha Sekara Rasa has so many things now. Everybody be aware of what Sudha Sekara Rasa has. So don't think of using Sudha Sekara Rasa for very good for gastritis, let me use it for 6 months or 8 months, no, nothing like that. It has some hazardous ingredients as per modern this thing. Yes, you know, go to Sudha Sekara Rasa and just see what Sudha Sekara Rasa has. You'll be surprised to see what it has. So Lagu Sudha Sekara Rasa and Kamaduga Rasa is basically in symptoms like GERD. Whereas Sudha Sekara Rasa and Shankavati, I prefer the patient comes to you or having food, after half an hour having food. I do get something like bloating of abdomen, pain in the upper gastric region, or pain in lower abdomen, something like that. There, Shankavati is basically told Shula, Shankavati, Mahashankavati. So, and there are people, because Shankavati has a Shankabhasma, it is a popular prescription in Amlapitta. Because it has Shankabhasma, and Shankabhasma is a good this thing. And many people use Shankavati as calcium supplement in golden because it has Shankabhasma. I typically use Shankavati in problem not associated or with GERD or acid reflexes and other conditions, even Sudha Sekara Rasa. So where you have pain below the abdomen, below the lower abdomen, half a pain or bloating sensation, a feeling of uneasiness causing after half an hour of abdomen. And I typically use Sudha Sekara Rasa after food, not before food. And Sudha Sekara Rasa is one that where the patient complains of pain in the flanks, my side or below the inferior angle of the scapula. A patient comes with a pressure half an hour or 1 hour after having food. I pain in somewhere in shoulder. In these conditions, referred pain to these places. Use Sudha Sekara Rasa. Only one tablet daily after 1 hour after it gives a better result. Not in GERD. GERD, it is always typically Lagu Sudha Sekara Rasa.
Next by Bhavana. How to differentiate between Amlapitta and Grahani?
Amlapitta and Grahani. See, again, that's why I don't want to get into this controversy. See, Grahani, Grahani is a big thing. Grahani, one GERD, Grahani, you can put anything and everything of lower GAT in under Grahani. Crohn's disease in the ulcerative colitis, then what is malabsorption syndrome, so many other conditions you can put under the head. Whereas Amlapitta is, for me it is acid, basically it is acid. But again, within that data comes into picture. If you want to know, then within that data, see, these are the few conditions, but typically, idam ittamata. So this is what is Grahani in modern terminology, and this is what is APD in Ayurveda terminology. It's very difficult to tell, but if the symptoms are associated with problem in second part of the digestion, means digestion of the food or meat, apart from gastric, after the digestion which has occurred in the stomach, like in the duodenum and other parts of the lower GAT problem, I take it as Grahani, or problem with absorption, reabsorption and other things, I do take it as Grahani. Otherwise, I take it as
Okay, this is a continuation of the question that was asked about that 20-year-old boy. So, Dr. Rahul Kujia asked that he doesn't have stress and patient is a construction worker and there is no refractive error.
construction worker, then ask him to take this what is Pratimarshanasya with the Shedbindu Taila or whatever, Chirabala Taila you will do. Then, as I told, apply either Chirabala Taila or Balahadani Taila on the head and ask him to cover his head, because construction workers, they are exposed to this cement and other things which are hazardous and continuously working under the bright sun. And working, if the person belongs to something centering and other things, or basically mason, at times they may work at a height of 20-30 feet from the ground. So, look into that from that angle, try to address those problems. So probably they will not be having their food regularly at times. So at times what happens, these people, they go early in the morning at 6 o'clock and work till 12 o'clock in the afternoon, then they have their food. They do these things. And if they are into concreting or madadito, they don't eat anything till they finish their work. So ask them to regularize the food habit, application of either Shirabala Tela or Balahadani Tela on the head, and using a Panama cap while working, and Pratimarshanasya. Along with Patyaka Kashaya should be there with Buddha and Shirashula Rivatira. To the Shekaravasa. Let him do this and let him get back. I think it should be good.
Sir, how to understand the concept of aura in Ayurveda?
Aura in Ayurveda. See, aura in Ayurveda, I don't know. I don't understand. See, this is the problem when we try to understand, try to interpret something which has been told in which has been understood with a totally different knowledge and try to incorporate into something else. So it is something like how to understand infection in Ayurveda. The easiest thing is to tell is ama. But Yella ama cannot be infection. Infection can be ama. So all amas need not be infection. This is also something like that. See, this also comes in symptomatology of whatever we speak, Ardhava Vedaka or whatever. But our understanding in Ayurveda, sorry madam, you better ask the person from the Kriti Vijnana who has done his master's in Kriti Vijnana, they may be able to tell you Bhoganidana or Kriti Vijnana. So I don't want to tell something which I don't.
Okay.
Sorry, I'm not able to address this.
Okay. Dr. Viresh has raised his hand. Doctor, do you have some inputs or you want to ask anything here in this context? Dr. Viresh, you may please unmute yourself.
Sir, what is the general routine that we can advise the healthy persons to come out of this ground or some APD conditions?
Pardon? I didn't get you. For a healthy person?
So what is the routine we can advise so that people should not go into this APD conditions?
Severe headache conditions. Huh?
No, APD. I think it is APD.
Object disorders.
It is simple thing. Whatever Ahara Paddhati has been told in the sea. Avoid all this. What is Adhikashana, Adhyashana, Kalatita Bhojana, Viruddhashana. Simple. Have regular food, timely food. You know your gut. You know your gut. You know what is easy for you to digest. And especially what happens is, see, there are few professions where you don't have a choice in what you eat. For example, people working in transportation, industry like bus drivers and lorry drivers, they eat when they get a choice to, time to eat. So there it is inevitable. But when you have an option to choose, see, for me, it is simple, bland food. It's easy for digestion. Having said that, see, food is something which your focus on your answer. See, a person for me eating a kadak jawari roti, I cannot be able to digest. One day it is good, but if I make a attempt to eat it daily for a week or so, my gut will not listen to me. So know your gut, know your roots, know which you are habituated to, what kind of food, and don't take curd in the night. That is something which has to be told in Ayurveda. It doesn't help. See, your first meal should be a heavy meal and the evening meal should be a light meal as far as possible. So don't take something like sweets and other things at night. See, dessert is a concept which has come from the Western country. So don't think of eating sweets or heavy food after completing your food. Sweets should come in the middle of your food, not after having curd rice or butter, something like that. So don't think of having food which are heavy for digestion at night times. So night time should be always light. And see, know your gut means know your your ability to digest something, and your gut, that is your koshta, ability to assimilate and convert. So know your agni, know your koshta. Eat accordingly. See, you cannot have a universal diet for every person on this planet. No. That is totally individualized. Say, for a person like me, I am happy eating bland. I can't tolerate spice. So I don't eat spice. I can't tolerate deep food. I don't eat. It's as simple as that. Over a period of time, you know what you see. Once in a while you eat, okay, fine, not an issue. But indulging is something, knowing that it is not good for you doesn't help. So common thing is eat timely. See, there is a rule now. Don't eat to your satiety. Is whatever it should be less. Use good quantity of water and use fiber. See, fiber is all those desi vegetables what we call all these gourds, bitter gourds, agad, they are good. So using more of the tubers is not good for some people. So you know your gut basically, and universal isn't any love. There is nothing called universal or 1%, like what they give now. 2 chapatis, 50 gram dal, 100 gram rice. You can't individualize your diet. Generalize the diet. It is individual, but basically this is what it is. Samasana. One single word if you want to tell samasana, that is eat at time, eat with a control. Eat what is good for your body. That's all. It is individualized.
We have another question by Sri Lakshmi. She asks, sir, I have a patient with severe bloating abdomen, recurrent burps, and taking pain since many years. Patient is very lean and reduced appetite. Symptoms did not subside with Ganavati Vati. Could you please guide in this case?
First thing is get an upper GS done. Make sure that there is no chronic inflammatory condition of the GI. First thing is, then if the patient is lean, then see whether there is melena. If the patient has any upper GI bleeding, make sure that patient has no upper GI bleeding, because you may have a chronic ulcer, non-healing small ulcer, or chronic inflammatory condition of the GIT, which is causing this. So make sure the patient has none of them. Then bloating is there, burp is there. Initially start with Avipattikara Churna, Sudarshana Rasa, Jirakavishta for a week or so. After 10 days, then see is there any change. Or you can even think of Ashtachurna if there is lot of practice. If burps are more, then go for Avipattikara Churna, Sudarshana Rasa, Dakviloha is one. Start with Dakviloha, Sudarshana Rasa, Avipattikara Churna, Jirakavishta, or you can think of Balajirakadi Kashaya. Basically it is told in Swasa Kasa, but still Vatam, something like that. Balajirakadi Kashaya or Itukanta Kashaya. It should help.
Okay. We have Supriya raising her hand. Supriya, do you have any questions?
Yes, ma'am.
Yeah.
Sir, one thing which I have noticed, whenever I try to start Prathamakshanasya with Ganapala as a Dinacharya process,
Your voice is breaking.
gastric symptoms start aggravating. That is nothing but
No, your voice is breaking.
Dr. Supriya, can you repeat the question? All I understood was whenever you start Pratimarsha Nasya with Anutaila, something aggravates. But what aggravates?
Gastric symptoms aggravate.
Yeah, whenever I start Prathamaksha Nasya, as a Dinacharya process, whenever you start it, I have observed that sometimes there will be aggravation of like I'm a known case of hypothermia, so the symptoms will start aggravating. But I don't have sinusitis and I go with Pratimarsha Nasya. How to practice?
See, with the sinusitis, if you don't use put eye, the better what you do, you go for Padavananasya. See, best is Shunti and Pipali Padavananasya. I mean, Nagara and Pipali Padavanasya. So if you have, see, many times, whenever you have sinusitis, like if you put some oil, or if you put anything, sometimes it triggers the pain also. So better do Pradhana Nasya is a better option if you have chronic sinusitis. And Pratimarsha Nasyadali, the quantity of oil what we instill is so small that it should not cause any problem. I mean, it will not reach the throat only, so it should not cause any GI disturbance. But Pratimarsha Nasya is aggravating your sinusitis. See, do Pradhana Nasya with Nagara and Pippali Choda Parvanti. You will have better results.
Okay, thank you, sir. And but what about the quantity of Nagar and Peptic there?
Oh, madam, we mix it in equal quantity. You know, the 1 muchuti is the dose which has been told in Shastras for Pradhana Nasya. One pinch.
Yes.
Together 1 pinch. That should be good enough. Either you can snuff it, or as told in the book, put it into extra and just puff it into the nostril. That thing can do. No, Pradhana Nasya will be better result.
Thank you, sir. Yes, sir, please.
Okay, now I consider that all the questions and answer sessions are completed, and it was a really very interactive session, Dr. Ravindra G S. I thank you wholeheartedly for agreeing my request to do this webinar, and I'm sure that it has helped all our participants today. So, thank you so much, Dr. Ravindra. A big thank you to all our participants who have joined us today. Your enthusiasm motivates us to keep creating such meaningful learning opportunities. And of course, big heartfelt appreciation to the entire AyurCentral team, tech team, which has ensured that the session has moved on seamlessly and hassle-free. I see Dr. Anurag raising his hand. Do you have anything to ask, or shall we conclude the questions? But that could be accidental raising. I don't have a reply from him.
Yeah.
So, thank you so much. And before closing, I would like to give this gentle reminder to all our participants. So, the doctors who wish to connect with us for bulk orders or for our in-house products or for the whole medicines for clinical practice, kindly reach back to me with the email that I have shared you for the link and the registration. So we'll be glad to support you and partner in spreading the reach of authentic Ayurveda across India. Once again, thank you everyone. We will look forward to see you in our upcoming webinar. Thanks everyone.
Thanks everyone for your patience hearing. I think I was of some use. If somebody can give me some other tips or what they have been practicing, it will be good for me. I think I was of some use for you people. Thank you. Thanks for the opportunity.
Yeah, thank you so much. I'm concluding the session. Thank you everyone.